Hello, this is Francisco La Rosa. I'm a pathologist, associate professor at the Department of Pathology of the University of Colorado Anschutz Medical Campus, and I will talk about the updates on the latest classification of urothelial cancers. And thank you very much to David Crawford for this kind invitation. We are going to start with some basic historical facts in the evolution of the classifications of urothelial cancer. In the 1800s, there was no microscope, even though it was invented in the 1600s. But at this level, in the 1800s, the pathologists didn't have yet a microscope, and there was no specific histological characteristics. Everything was cross-examination, as the work done by Dr. James Paget and Ashley Cooper, both from England, and then they were basically the founders of scientific medical pathology. Both in them were describing different aspects, not only in live patients, but also in autopsy cases. And even Dr. Cooper has several anatomical structures with his name. In the early 1900s, the advent of the microscope gave origins to the new specialty of histopathology, and then pathologists were able to identify the different aspects of the cancers, not only in the bladder, but in many other systems. And the first time that the transitional cell carcinoma nomenclature was introduced in the medical jargon. And it was in the mid-1900s that Dr. Brothers at the Mayo Clinic started to collect cases and to be able to identify that cancers of the same histological type behave differently. And this gave origin to classifications of squamous cell epithelioma that inspire other scientists like Dr. Dukes, who made the first classification of cancer of the rectum. But Dr. Dukes was also very interested in genitourinary diseases, and in 1939 even wrote one of the first books in the examination of the urine, and later on he became even president of the section of urology of the Royal Society of Medicine. It was just in 1952 that the first significant classification was introduced by the Armed Forces of the Institute of Pathology, the AFIP, and then the first classification of urinary tumors in grades 1, 2, 3, and 4 was established. And this was the basic nomenclature that lasted until 1973, when the WHO introduced the first classification of bladder tumors, and they review all the different kinds of tumors that were already described. And the first time that the term papillary urothelial neoplasm of low malignant potential was introduced, as well as the gradings. These 4 grades from the AFIP were reduced to only 3 grades, and then based on the atypia and the cell differentiation. It was not until 1981 that a review from the WHO of this classification, they retained the 3 grading system, but they refined a little bit more the reproducibility and the inter-observer variability that was present at that time, and with correlation with the clinical relevance. It was in 1998 that, again, the WHO, in association with the International Society of Urological Pathology, they did the first consensus classification, and then this classification was reviewed in 1999. What they did first was get rid of the 3 grades of classifications in the tumors, 1, 2, 3, and they just called them low-grade and high-grade carcinomas. But in the 1999, they changed their mind, and they went back to the 3 system, the 1, 2, and 3 papillary urothelial carcinoma. Anyway, this is just to see how the evolution of these gradings came from 1973 to 99 in the different stages of classification, 73, 98, and 99, and also the different ways that they were able to change the concepts for the classification of high-grade and low-grade tumors. And then now, in the 5th edition, the last one in 2022, now the WHO has made a very interesting comprehensive update of the terminology, together with the epidemiology, pathogenesis, histopathology, molecular pathology for the first time, and relationship with the prognosis and predictive progress of these tumors. The classification in 2022 has already eliminated the term of urothelial dysplasia because it's a very contentious term that it produces a lot of inter-observer variability, and then is not synonymous, it's not related with the real relationship with carcinoma in situ. And then the new classification is mentioned in the discussion of CIS, but is not included in classification. The other term that has been eliminated is the urothelial papillary proliferation of undetermined malignant potential. It was a kind of a funny term that I think that it helped the pathologists to cover our ignorance. And many times we just use this term as a kind of a wishy-washy diagnosis. And this lesion that has no place in the new classification. So now we have this non-invasive urothelial neoplasm with all these different varieties. Most cases are originated in urinary bladder with about 5 to 10% occurring in the upper urinary tract. Now, the reporting of the gradings now has been reduced to only low grade and high grade. However, the tumors in some cases, they can have some fractions that may be interpreted as high grade. If the tumor has less than 5% of high grade fraction, they need to be reported like low grade tumors with a less than 5% high grade component. And this is more acceptable and more realistic. So they can send a flag to the urologist that maybe in the future this patient have a higher grade tumor, but still is more than 95% a low grade tumor. So this is a more pragmatic approach of reporting results that has been adopted. And then we have all the classification of the invasive tumors with the different varieties of squamous, differentiation, glandular, plasmacytoid, micropapillary, etc., that are important to mention in the diagnosis, also in the regards to the percentage that they are present in the tumor, because it's not the same to have a squamous cell carcinoma with only 5% to 10% presence versus a 95% presence of squamous cell differentiation that is going to have a significant impact in the therapy and the prognosis. And then we have all the other pure cancers like squamous papillomas that are only squamous origin, verrucous carcinoma, pure squamous cell carcinoma of urinary tract, etc. And the same for the urachal and urethral neoplasms and the Mullerian types, and also the glandular neoplasms. So all these cases, they have histological subtypes, and they are basically considered high-grade tumors. The molecular classification is the new baby in the classification. It hasn't been touched in previous classifications, and it's very important because it's identified in carcinoma, and then the cancer 5 key molecular subtypes, including 3 subliminal subgroups, cluster also. And this each subtype, their prognosis that are different, and the treatment response. So, but still we need to have better consensus in the molecular classification, because this classification works in some patients, but in others, and it's not that general as we would like to have it. And this is just one of the simplified representations of this evolution of bladder cancer from the papillary and not papillary pathways all the way to the molecular subtypes in regards to invasiveness and the presence of metastasis. This is what the Cancer Genome Atlas is been working on, and they have a specific marker for different kinds of cells in the tumor. For example, the luminal papillary is characterized by the presence of F3FR3 and also other markers that they are related with the papillary morphology. So all these markers, those are tumor markers and molecular markers, have been analyzed from different institutions. And so this is the results of the consensus that was obtained with more than 1,500 specimens that were generated from different institutions that have given the origin to the identification of luminal papillary pattern in 35% of the cases, what is called luminal infiltrated, and 18%, luminal pure 6%, and then the basal squamous and the neuronal. A total of 6 molecular classifications for muscular invasive cancer that are underway at this moment for the consensus classification. And this is the Paris system for reporting cytology with the relationship with the risk of high-grade malignancy. So in cases of negative high-grade cancer, you can see that there is still a possibility, even in negative samples, to have between 8 to 24% malignancy. So when we have a negative cytology, we still are not able to completely rule out the presence of cancer. With the increased finding of atypia or the suspicious findings of high grade or the positivity of high grade, then the risk of high grade cancer is increasing, and then we can find a better cytological and clinical correlation in these patients. So this is a summary. The first edition, the WHO in 1952 was able to start these attempts for classification of these tumors, and the last one in 2022. So these are the references that I've been able to review. Thank you very much for your time.